Type 2 diabetes mellitus. Type 2 diabetes mellitus consists of an array of dysfunctions characterized by hyperglycemia, resulting from the combination of insulin resistance, inadequate insulin secretion, and excessive or inappropriate glucagon secretion. According to World Health Organization, in the year 2014, 8.5% of adults aged 18 years and older had diabetes. In 2016, diabetes was the direct cause of 1.6 million deaths. The International Diabetes Federation predicts that globally, the number of diabetics will rise to around 552 million by the year 2030. Type 2 diabetes develops when a diabetogenic lifestyle, characterized by excessive caloric intake, inadequate caloric expenditure, obesity, is superimposed on a susceptible genotype. The major risk factors for type 2 diabetes mellitus are age greater than 45 years, overweight or obesity, first degree relative with type 2 diabetes, history of previous impaired glucose tolerance or impaired fasting glucose, history of gestational diabetes mellitus, history of delivering a large baby, and having polycystic ovarian syndrome. Type 2 diabetes is characterized by a combination of peripheral insulin resistance and inadequate insulin secretion by pancreatic beta cells. Insulin resistance leads to decreased glucose transport into muscle cells, elevated hepatic glucose production, and increased breakdown of fat. Islet parachronopathy leads to the loss of reciprocal relationship between the glucagon-secreting alpha cell and the insulin-secreting beta cell, which results in hyperglucagonemia and consequent hyperglycemia. Prediabetes is defined by a fasting blood glucose level of 100 to 125 mg per dl or a 2-hour post-OGTT glucose level of 140 to 200 mg per dl. Persons with prediabetes are at increased risk for macrovascular disease, as well as diabetes. Most patients with type 2 diabetes are asymptomatic. The classic symptoms of diabetes are polyuria, polydipsia, polyphagia, and weight loss. Other signs include blurred vision, lower extremity paresthesias, and yeast infections. According to American Diabetes Association, the criteria for diagnosis of type 2 diabetes include either of the following: an HbA1c level of 6.5% or higher, a fasting plasma glucose level of 126 mg per dl or higher, a 2-hour plasma glucose level of 200 mg per dl or higher during a 75-gram OGTT, a random plasma glucose of 200 mg per dl or higher in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis. The indications for diabetes screening in asymptomatic adults includes sustained high blood pressure, or overweight plus one or more diabetes risk factors. American Diabetes Association also recommends regular screening after 45 years of age in the absence of the two criteria. According to the European Association for the Study of Diabetes and the American Diabetes Association, the physician must individualize glycemic targets and treatment according to the patient. Diet, exercise, and diabetes education should be the foundation of anti-diabetic therapy. Metformin should be prescribed as the first-line drug, adding 1 or 2 oral or injectable agents, with the goal of minimizing adverse effects, should be considered. If these treatments fail, insulin therapy alone or with other agents should be prescribed. All decisions should involve the patient, with a focus on patient preferences, needs, and values. Another chief focus should be on comprehensive cardiovascular risk reduction. According to American Diabetes Association guidelines, patients on intensive insulin therapy should do self-glucose monitoring before meals, at bedtime, before exercise and critical tasks, when hyperglycemia is suspected, and after treating hyperglycemia until normoglycemia is achieved. The approaches for preventing diabetes complications include regular HbA1c tests, dilated eye exams, microalbumin test, and foot exams. The blood pressure should be maintained less than 130 by 80 mm Hg. Statin therapy should also be prescribed to reduce low-density lipoprotein cholesterol. Reversion to normal glucose regulation during attempts to prevent progression of prediabetes to frank diabetes is a good indicator of slowing disease progression, and it is associated with a better prognosis. Tight glycemic control is valuable for preventing microvascular and macrovascular complications in patients with recent onset disease, no known cardiovascular diseases, and a longer life expectancy.